Thank you for joining us today. My name is Annie Prasad. I am the Product Marketing Manager at Springer Publishing. Today we are presenting the Great EKG Challenge with Maureen Knechtel. Maureen holds a Bachelor of Health Science and Master of Physician Assistant Studies, as well as a Doctor of Medical Science with a focus in medical education. She has spent her clinical career as a physician assistant, specializing in general cardiology and cardiac electrophysiology. She teaches electrocardiogram recognition and interpretation to both physician assistants and nurse practitioners. Before we begin, a quick reminder. This webinar is being recorded and will be available on demand at springerpub.com/videos in 5 to 7 days post-live event. If you have any questions, please type them into the Q&A box on your Zoom control panel. I'll bring them up at the end of the presentation. If you forget to ask a question, there will be a brief survey sent at the end of the webinar, and you can include your question there. Now let's get started. I'll turn the presentation over to Maureen.
Thanks so much, Annie. Thank you so much for joining us today. We're going to take a case-based approach to EKG interpretation. And so if you want, you can answer the first question here. Tell us what your primary role in healthcare is, and then we'll get started. Okay, so we have a nice mix of people present today. It's great. Okay, so we'll go ahead and get started here with our presentation. Thanks so much for joining us. Here are a few objectives that we're going to try and cover. So we're going to apply some clinical vignettes to an EKG tracing, and then we'll have a multiple choice question. So this is going to be somewhat of an organic process where the discussion will be really based upon your responses. If you have questions, you can feel free to enter them into the chat, and we'll hopefully you'll learn some new skills, tips, and tricks for EKG interpretation today. Here's our first question. You are rounding at a high-level cardiac hospital when your 84-year-old female patient with type 2 diabetes and hypertension develops shortness of breath while she's walking with physical therapy. You can take a look at the vital signs there. So you get called to come check on her. And by the time you get there, she's got some shortness of breath and chest pain previously, but everything has gotten a little bit better. She's feeling okay. But you obtain a stat EKG, which you can see here. So I'll give you a little bit of time to take a look at that tracing, and then we'll pair it with the multiple choice question. Okay, so you'll still have some time here to look at the tracing, but let's pair this with a question. So based on your interpretation of this EKG, what do you think is the best medical intervention? So based on your interpretation, what would you do? You're in charge. Okay, let's see what we've got here. So most people chose correctly and said activate the cath lab. So activate the cath lab, give some aspirin, ticagrelor, and that is the correct answer. We also, it's about 65% said that, and 29% order stat troponin followed by a stress test, and then a small percentage said no intervention needed at this time. So let's talk about why letter B is the right answer option. So first, let's talk about the interpretation of this EKG. This is a really interesting phenomenon called Wellens syndrome. And there's a cardiologist named Wellens that has several criteria and several things named after him. And so back in 1982, there was a landmark study that came out that showed that patients with this particular pattern, I'm going to go to the next slide and show you what those criteria are, and then we can always go back to the tracing. This particular pattern looking at leads B2 and B3. And so you can see these characteristic changes. So we've got biphasic T waves or deeply inverted T waves in precordial leads, but specifically B2 through B4, most prominent usually in B2 and B3. These changes suggest high-grade proximal left anterior descending artery stenosis, and this is referred to as a pre-infarct state. What that means is the person is at risk of developing a really significant STEMI if left untreated. And so this study had a pretty good a number of patients, good sample size, and showed that these patients that would come in, they'd have a recent history of significant chest pain consistent with angina, usually exertional type symptoms, and they'd show up in the emergency department and be chest pain free. They're relatively stable, chest pain free, but then they get this EKG, and it just something just doesn't look quite right. So go back to the tracing. We can see here in lead B2 and B3 in particular. You can see really those kind of biphasic T waves with that deep inversion in the terminal portion of the T wave. And so, in a chest pain free setting, it can be easy to look at that and say, I know the EKG doesn't look great, doesn't have that real classic tombstoning of the ST segment, but you should recognize that there's clearly some T wave inversion. It doesn't look quite right, but if the patient is asymptomatic, it can be easy to say, maybe the patient's fine, maybe we can just order a troponin, do a stress test. But these patients, without prompt intervention, a significant percentage, like 70% of these patients, will go on to develop significant anterior wall infarct. And so this is something that you should recognize quickly, activate the cath lab. And so if you don't do anything, they can really go on to have a poor outcome. So the patient may appear clinically stable in between episodes of pain, but it is a true pre-infarct state. And I think we used to look at these and say, that this is something that maybe we can trend this out or monitor it, but really you need to intervene quickly. There's no reason not to. When we think about the evaluation of patients, this is one of those high risk EKG findings, and I would classify this as a can't miss EKG. So we wouldn't want to give, you might think, well, why not nitro? Why can't we give nitro? Looking at the whole clinical scenario, the patient's hypotensive, relatively hypotensive, given the presentation. If we were to do a stress test on this person, we could, potentially have a really bad outcome. We wouldn't want to do that. So giving them that initial antiplatelet therapy, activate the cath lab, is going to result in an outcome for your patient. Wellens anterior ischemia, one of those can't miss EKG. All right, let's go on to our next case. We have a 74-year-old man who's coming into the office for evaluation of syncope. EKG from 2 months ago, you're able to pull that up and you see the patient has a left bundle branch block and a first degree AV block. Okay, that's the previous EKG. Since then, PCP has added a beta blocker for management of hypertension, and the patient now comes in for an appointment because he has passed out. And here is today's EKG tracing. So take a look at that, see what you think. You'll still have a chance to think about the tracing some more, but we'll go ahead and pair that with a multiple choice question. So now we're asking simply, what is the current tracing reveal? What is your interpretation? Someone hands you this EKG, what would you say? Okay, you guys are doing great. So the correct answer is that this now shows a complete heart block. Other answer options, the next most common choice that was chosen was a Mobitz Type II block. All right, so let's talk about this. This is an example of complete heart block. And another one of those, I'd say can't miss EKGs. So you don't want to miss complete heart block. And if we look at this EKG, how do we know that? So the key thing is that there is evidence of atrioventricular dissociation. So step one, we've got a slow heart rate. Okay, the heart rate's definitely slow. So there's bradycardia. And then the very next thing you want to look at after you figure out what the rate is, and so we can count up 1, 2, 3, 4, 5, 6. So 6 QRS complexes in the rhythm strip along the bottom. We multiply that by 6. We can get 36 beats per minute. So there is bradycardia. And then the next thing you want to do is evaluate the P wave. What is the P wave doing? So with any of these types of heart block, Mobitz type 1, Mobitz type 2, complete heart block, how do we define those things? Well, the easiest thing to look for is the association of the P wave with the QRS. Okay, so with a Mobitz type 1, we have a progressive lengthening of that PR interval before there's a drop beat. So with a Mobitz 1, you're going to see dropped beats. With a Mobitz type 2, you're also going to see drop beats. Okay, we don't see that along the rhythm strip along the bottom. So EV1 rhythm strip, there's no drop beats. So Mobitz 1, Mobitz 2 becoming less likely. No change from previous tracing. Now that you might be tricked into that because the patient does have a left bundle branch block appearance to this EKG, which also goes along with heart block. So in this example, though, the key is to look for P waves that are not associated with a QRS. I'm going to pull up my laser pointer here and just show you. Here's a P wave. This is a P wave. We got a P wave here and here and here. So now if we just look at this first beat, you might look at that P wave and the QRS and say, yeah, that looks pretty normal. But then that P wave is probably not causing that QRS complex. And then I've got two P waves here with no QRS in between. When you want to define AV dissociation, try to find two P waves that are close to each other. I can clearly see this is a P wave and this is a P wave. Figure out what that interval is and then try and march that across the page. And you'll see that those P waves should come in predictably because life is good if you're the P wave. Your sinus node, you just set the impulse and you don't really care about what happens as you move down the conduction system. So those P waves are going to come in predictably at the same time. And then because there's a blocking at the level of the AV node, we have an escape focus that fires off. And the lower in the conduction system that escape focus comes from, the slower the heart rate is going to be. So if you see something that's really big and wide, QRS complexes that are associated with a slow rate, you should think about the possibility of that coming from somewhere in the ventricles. That's also helpful clinically because you can have a complete heart block that has faster rates that might be a little bit more stable as opposed to something that's slower because the lower the focus is coming from in the conduction system, that means everything else above it has failed. So in this case, we can see this is a ventricular escape focus. And because that escape focus is coming from the ventricles, it's going to give an appearance of either a right or a left bundle branch block. And that's why in this case, we've got, it looks like a left bundle type appearance, but that's not what it is because there's complete heart block. So we want to make sure we can recognize complete heart block, definitely a more concerning pattern than some of the others. So AV dissociation is what defines that for us. So let's look at a couple take-home points from complete heart block, in addition to what we already talked about. So being able to recognize AV dissociation, the most important thing, the slower the heart rate, the lower in the conduction system the focus is coming from, and that means the patient is potentially more unstable because everything above that in the conduction system has failed. Clinically, how can we put this into practice? If you have a left bundle branch block and a first degree AV block, there is a slightly increased risk of progression to some type of high grade AV block. Now that usually is about 10% or less. So that's not super high, but that will be higher depending on other things that might be present. So things like the patient's already got, they've got coronary disease, valvular disease, other things that might potentially increase the risk of that, of a more significant heart block. You want to be really careful when you start adding medication. So if we're treating something like hypertension, is there another agent that we can use that's not going to slow down the heart rate because we don't want to increase the risk of progression of conduction system disease? So being able to recognize complete heart block was the most important thing, AV dissociation, and then secondarily thinking about the patient and how stable or unstable they might become based on how slow that heart rate is. Next case. A 65-year-old woman presents to the ED with crushing substernal chest pressure. Based on this tracing, what medication should be used with caution? So now we're we're going to make the question a little more difficult. So first you have to be able to interpret this tracing, and then how might your interpretation affect your clinical intervention? Okay. So, oh, we got some different answers here. So, uh, the highest percentage was chose beta blockers with caution. Beta blockers followed by nitrates, which is the correct answer. Nitrates is the correct answer. This is one of my favorite EKGs to try and identify, and it's one of the things that can really make you look like a rock star in clinical practice if you know what to look for. I think most of us can look at this EKG right away and recognize that there is an inferior STEMI. So 2, 3 AVF is the inferior wall, right coronary artery. And hopefully we can all appreciate there's some ST segment elevation. Remember, with ST segment elevation, you think about that J point where the QRS joins up with the ST segment. It's like you just take your fingers and you pick that up off the baseline. That's ST segment elevation. And we want to look at more than 1 or 2 millimeters or small boxes off of baseline. Okay, so when you're looking for a STEMI, remember reciprocal changes are really helpful to confirm that. So we've got ST segment elevation 2, 3 AVF, and then the reciprocal changes that we're going to see that confirm a STEMI in the inferior wall, we can see in the lateral leads, 1 and AVL, and we can definitely see some ST segment depression there in 1 AVL. So we should be feeling really good about this is an inferior STEMI. And of course, as we know, STEMIs are can't miss diagnoses. So if we're affecting the right coronary artery, here's where the interesting part comes in. So what you want to be able to pick up on this EKG is, in addition, we've got what looks like ST segment depression in V1, V2, V3, and really it extends all the way over into V4. So we typically think about V1 through V4 as telling us about the anterior leads. But in the setting of an inferior STEMI, you should always look at those leads to tell you about the extent of the myocardial involvement. And this is actually showing us posterior wall involvement. And for if anyone has ever seen someone, usually it's in the ED, that's when you're seeing STEMIs, you get an paper EKG and they flip it over and look at the backside and hold it up to light. You might think, what are they doing? Well, what you're actually looking for is you're trying to take the vantage point of the posterior wall of the heart, because none of the standard leads on a 12 lead tell us about the posterior wall. But that's a whole portion of the heart that we don't want to ignore. And so these leads are actually showing us um, reciprocal changes of the posterior wall. So we're taking the vantage point when we look at an EKG upside down. We're saying, I'm going to look at the backside of the heart and I'm going to look at the anterior leads. So you can imagine that if you were to take V1 through V4 and you take this EKG and flip it up, it would look just like ST segment elevation. And so that's telling you that there's pretty significant um, eh, damage there that's ongoing. So this is telling you about that right coronary artery wrapping around, supplying the posterior wall, and the potential for right ventricular involvement as well. So that's what posterior ischemia tells us. And if we think about the coronary anatomy, everybody is either right or left dominant. So your posterior wall of the heart is supplied by either the right coronary or the left circumflex. So you can also see posterior involvement with left circumflex lesions. So you should always look for that. And so if we see that, it just tells you about the potential extent of ischemic involvement. And so let's go to the next slide here for a few take-home points so I can show you a picture. So here we've got left circumflex and right coronary artery, isolated posterior wall infarction, like if it's an embolus, that is it's not very common. So when you see posterior involvement, you're much more likely to see it with either an inferior or a lateral STEMI. So are you going to treat the patient differently? Maybe. You're still going to activate the cath lab, but why is nitro something that we have to be careful about? Because it produces preload. So nitroglycerin is going to be it's a massive vasodilator. That's why it works really well for acute coronary syndrome. But when we massively dilate, we can drop the preload or what's coming back to the heart. So if I've already got a right ventricle that's potentially damaged, and when the right ventricle is not great, it's not a great pumping vessel like mechanism like the left ventricle is. It's much smaller, and it's not meant to withstand lots of high pressure. So if we have right ventricular involvement and the right ventricle is already having trouble accommodating fluid, and then you change the preload, we can actually cause some damage there, where patients can develop some difficulties with their ability to manage volume. So, potential risk of hypotension if the right ventricle is compromised. Nitroglycerin can further exacerbate that hypotension, which is very good at dropping the blood pressure. And so, it's not that you can't give nitro, you just want to be aware of how do I diagnose posterior involvement and then manage your patient. Just look at them, evaluate them, be aware. You want to pay a little closer attention. Are they starting to develop pulmonary edema? Things like that can be a little bit more concerning. So that's posterior wall involvement, and we see that most commonly with inferior STEMIs if it does occur. I see a question here. Um, yeah, so there's a question comment here. You don't give nitrates. Yeah, so it generally it's not that nitrates are absolutely contraindicated in inferior STEMIs. It's that you should use it if you're going to use it, make sure you use it with caution, and that's the mechanism there. So inferior STEMIs, use nitrates. If you're going to use them with caution, absolutely. If you've got posterior involvement, that's just a little clinical pearl. An extra thing you can look for that would make you be extra cautious. Maybe I'm not going to use it at all. So nitrates with posterior wall involvement should really give you some pause there. Okay, let's go on to the next case. So we got a 62-year-old female with coronary disease, hypertension, hyperlipidemia, 2 episodes of near syncope in the past 48 hours, no recent chest pain, shortness of breath. So she's not actually passing out, no syncope, but feeling like she's going to pass out. Sitting in your office, currently asymptomatic. This is her EKG. All right, so we'll take a look at a question, and you can look at the EKG a little bit longer. So this one, just want to know, what is your interpretation? What do you think is going on? Okay, so let's look at our answers here. 52% said Mobitz Type II, and the next most common response was a Mobitz Type I, which is great. That's exactly what you should be thinking about with these two. So how do we tell the difference between a Mobitz 1 and a Mobitz 2? I'm going to go back to the larger tracing, make it a little bit bigger. Okay, so with Mobitz 1 and Mobitz 2, second degree type 1 versus second degree type 2, they are both going to be associated with a slight irregularity to the rhythm. So that's one thing that should make you think about, what is my differential diagnosis? Lots of things can do that, but we look like we're dropping beats. Okay, so let's look here. Here's a drop beat, and here's a drop beat. When you see a drop beat, a dropped QRS, you want to look at the PR interval that's right before that and the PR interval that's right after that. And we want to see, is it changing at all? Okay, so here's the P wave with nothing after it, and then here's a PR interval, and this PR interval here, and I would say that they look the same, but let's try and trend that out. So do we see that PR interval changing at all? And it's really not. It's not changing. And I always say, don't just rely on your eyes. Always get some calipers and try and measure that to be completely sure. So this is a Mobitz Type II, and let's talk about some take-home points with that. But first, before we do that, so right bundle branch block, you can have a right bundle branch block in addition to another type of heart block, because a bundle branch block is occurring at the level of the ventricles, and then a second degree block is occurring at the level of the AV node or the bundle of hits. But in this case, it's not a right bundle morphology. It's actually a left bundle morphology. We talked about why it's a Mobitz 2 and not a Mobitz 1. And then complete heart block is going to give a regular rhythm. This is not regular, so relatively regular rhythm with AV dissociation. And so we don't have AV dissociation. There is definitely association between P waves and QRSs. So what are some take-home points with Mobitz 2? Here's a comparison of Mobitz 1 and a Mobitz 2. With a Mobitz 2, we call that infrahisian, meaning it's just lower in the conduction system. Remember, the lower any type of block is in the conduction system, the more unstable it is. And the difference between, you have to be able to recognize the difference, because a Mobitz 2, generally, as long as it's not immediately reversible, requires a pacemaker, whereas a Mobitz 1 may or may not. In fact, usually it doesn't require a pacemaker, depending on what else is going on. So Mobitz 2, high progression, high chance of a progression to significant AV block, complete heart block, very unpredictable. You don't know when those drop beats are going to occur. So with the Mobitz 1, here's a drop beat, okay, dropped QRS, and let's look at the PR interval right before and the PR interval right after. And what you'll notice is this one is slightly longer than this one. And you'll see that that PR interval just gradually lengthens, lengthens, lengthens before there's a drop beat. So with the Mobitz 1, it's like the sinus node is talking to the AV node, but moving farther and farther away, and eventually it can't hear and it drops that beat. With a Mobitz 2, there's no way to predict when that's going to happen. As you can see in this example, we've got a PR interval that actually looks okay, looks fine. But then we have a P wave with nothing after it, and then some normal beats here before we start having drop beats. And that's the concern with the Mobitz 2, is that they can go on to develop ventricular standstill if nothing pops in and helps pick up the difference. Okay, so Mobitz 1 versus Mobitz 2. I work in electrophysiology. We get referrals a lot from the sleep lab. And so um, I would ask you, why do you think that is? And the answer, as many of you probably know, is that there is a fairly, it's not insignificant association between sleep apnea, obstructive sleep apnea, and a Mobitz type 1. So we'll see that a lot of referrals for that. So that's a potentially reversible cause. Anytime you see this, you want to look for reversible causes, think about the potential for ischemia, and then initiate your work. Okay, next one. 35-year-old female with no significant past medical history, has palpitations and dyspnea, happen with activity. You can see the vital signs there. No prior EKG is on file. You try some carotid sinus massage and it's not effective. So step one, what do you think is going on with this EKG? And then we'll apply that clinically. Okay, so let's take a look here. Here's the EKG again. What would you do? What is the next step in the management of this patient based on the whole picture? Oh, great job. You guys know this one. So we give adenosine. That is correct. We give adenosine. Okay, other answer options. The next choice was a cardioversion. So in this case, you're always going to start with something like adenosine if the patient is stable. So step one, vagal maneuvers, of course. We want to try and slow within the AV node, because any type of paroxysmal supraventricular tachycardia that we're talking about here, So the most common types would be AV node, reentrant tachycardia, followed by AV reentrant tachycardia. Now, atrial tachycardia is another potential type that we group in that category, but in particular, AV-NRT, AV-RT, they require the AV node in order to both kind of initiate and maintain, but more importantly, maintain that SVT. Okay, so we have a reentrant circuit that is either occurring within the AV node itself or between the AV node and an accessory pathway. So we have to have some type of block. We have to block that reentrant circuit in order to terminate it. So we can use vagal maneuvers to try and increase vagal tone, block within the AV node. If that's always a great way, a great option. And then if that doesn't work, then you have a couple other options. You can try carotid sinus massage, or you can give adenosine. Okay, so at what point do we need to do a cardioversion? The answer really is if the patient is hemodynamically unstable. So she's feeling okay, she's otherwise healthy. Her blood pressure, some of you may have chosen letter A because you're like, I don't know, her blood pressure is a little low, which is a fair thought. But she's otherwise healthy. If her pressure is like 80 over, palp, then yeah, that's a different story. But in this case, she's probably going to respond really well to a little bit of adenosine. And so those of you that work in the hospital, that's everyone's favorite activity is giving adenosine. So you got to make sure you have a crash cart and you want to push that adenosine as fast as you can to try and break that rhythm. And so what you're doing is you're causing a temporary block within the AV node, which disrupts that circuit, and hopefully the patient will be fine. We wouldn't give amiodarone. There's no need to go jump to amiodarone. And then a diltiazem drip, if you did that, diltiazem, especially through an IV, very potent lower of blood pressure, and she's already 100 over 60. So you could take a relatively stable patient, make them unstable very quickly if you did that. So let's look at some take-home points for that case. Okay, take-home points for PSVT management depends on, as I said, hemodynamics, patient symptoms. We try vagal maneuvers, carotid sinus massage, followed by adenosine, and then you can cardiovert the patient, not defibrillate, if they're hemodynamically unstable. Okay, so that's going to be your management of PSVT. So we can see, how do we know this is PSVT? Because we've got a regular rhythm. So along the bottom, we can see that there's a regular rhythm. And I can't really identify P waves in that rhythm strip. So as I said, the P wave is really important in trying to identify what is going on with the patient. So we don't see clearly identifiable P waves, and it's a narrow complex tachycardia, so we should feel really good about calling this just simply SVT. Okay, next case, a 78-year-old man with hypertension, coronary disease, diabetes, tobacco use, got lightheadedness and palpitations. EMS shows up, blood pressure is pretty low. He does have a pulse, but he's not very responsive. Here's the EKG. Patient is cardioverted with successful restoration of normal sinus rhythm. So just take a few seconds and look at this EKG. And what would you say about this? What do you think is going on? So that's step one. And then we'll apply that to a clinical question. Okay, so you can still take a look at the tracing. And the question is, what is the next step in determining the etiology of this arrhythmia? Ooh, okay. So the majority were correct here and performed left heart catheterization, with the second most commonly chosen answer being performed EP study. So we have to think about, what is this? So this is a wide complex tachycardia. So even if you looked at this and you're like, I'm not sure, what's going on. If it's a wide complex tachycardia, the patient has a history of coronary disease, you're going to treat that like VT until proven otherwise, because that's the most likely scenario. Okay. What's the worst that could happen? Death and dying. We want to try to avoid that. So you want to treat it like VT. Let's go back and show you the slightly bigger one. Okay, so with VT, one of the most important things you want to try and look for is just like complete heart block, AV dissociation, because think about what's happening. We've got sinus node, life is good if you're a P wave, you just keep firing away no matter what. But then there's some type of irritability in the ventricles. Why does VT happen when it's related to a patient with coronary disease? There's some type of scar tissue, whether there's active ischemia or there's an old MI and we've got scar tissue. And as electricity spreads down through the ventricle, it kind of weaves slowly through that abnormal tissue. And in doing that, it can essentially circuit. And now we have a VT focus that comes around that abnormal heart muscle. And so we should see evidence of AV dissociation. Now, AV dissociation, you may or may not be able to see at faster rates with wider QRSs. It's very difficult. And that's why I say always fall back on if the patient has coronary disease and they have a wide complex TAC, we want to treat that like VT. But if we can see AV dissociation, and I'm going to try and point out a few of them here. Okay, so there's a P wave right there. Okay, where my pointer is, and probably right there. And so kind of what you want to do is just look and see where are there things that I don't see in other places, and that can help you pick out AV dissociation. But let's say you're still not sure, because as I said, when the rate gets faster, it can be more difficult. Here's some things that I look at. Okay, let's look at a list here. So as I said, treat it like VT until proven otherwise. There are many different criteria. Again, Wellens coming back in. These are Wellens criteria. There are Brugada criteria are a little more recent. But I think clinically, these ones are very, very easy to identify. So positive, negative concordance. That means the QRSs look the same across the precordial leads. They're in the same direction. They're predominantly positive or predominantly negative. Why is that important? I use that one a lot when I'm just quickly looking at an EKG, because QRS, R wave progression, will appear a very specific way in the precordial leads because of what's normally happening. Think about where lead V1, 2, 3, 4, 5, 6. They're in very predictable areas on the precordium. Electricity is going to start at the area of V1 and end at the area of V6. And with the precordial leads, you essentially want to take the vantage point. What am I seeing? As electricity is moving past me, what am I seeing? If I'm lead V1, everything's moving away normally. Okay, that's why lead V1 is predominantly negative. QRS is predominantly negative most of the time. That's normal. It's what it should be. V6, look at any given EKG that's essentially normal. V6, the QRS should be predominantly positive. Why? Because it sees everything coming towards it. Okay, that's so normal R wave progression goes like that. If you have VT, we have a focus that's starting somewhere in the ventricle and then just firing off erratically, not the way it should go. So the QRSs, everything there in V1 through V6 will kind of see electricity looking sort of the same because we're seeing it from a completely different vantage point. So QRSs are going to be predominantly positive or predominantly negative. Indeterminate axis for the same reason. Axis will look a certain way based on the flow of electricity. So if electricity is going in a completely opposite direction as it should, if it's going from ventricle up, the axis is going to fall in that no man's land category. It's not going to be right. It's not going to be left. It can be indeterminate. Don't hang your hat on that. But if you see an indeterminate axis with a wide complex tachycardia, that should move that VT higher up. AV dissociation, as I mentioned, the QRSs are generally regular. That's important because if you have AFib, a flutter with an underlying bundle branch block, you can have a widening of the QRS. But with AFib, of course, it's going to be irregular, not regular. And then a wide QRS. The farther away from the normal conduction pathway, a VT focuses, the wider the QRS is going to be. So let's go back to our tracing in the big picture here. Okay, positive, negative concordance. Let's see if we got it. QRS, negative, negative, predominantly negative. This is a T wave, not a QRS. So QRS is negative, 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 negative. Okay, so we have great example of positive, negative concordance right there. It's regular. The QRSs are wide. So we're feeling really good about calling this VT. All right, back to our question then. if we want to determine the etiology, we would do a left heart cath. So if someone's got coronary disease and they've got VT, that's what we would do. And you could make an argument and say, well, but you can tell from an EP study also. Yes, you can do an EP study and try and see if you can induce VT. I would recommend that in the setting of someone with coronary disease. So we're going to do a left heart cath and think, does this person have some type of an ischemic insult that's active that I can fix? So that's why that's the right answer. 22-year-old woman presents to the office with palpitations. She plays in a co-ed basketball league, has sudden onset, palpitations near syncope. There's her vital signs. What do you think is going on? We're thinking on this one. That's good. Okay. Oh, hyperkalemia. That's a great thought. So the answer is pre-excitation. The most commonly chosen answer was hyperkalemia, followed by pre-excitation. So pre-excitation is the correct answer. I'll tell you, this is a hard one. I'd call this a challenge tracing, but it's also one of my favorite topics to talk about. And I would say this is also a can't miss EKG. You may not see it very often, but we've got a 22-year-old. So if you're looking at this EKG, the first thing you should think about is say, oh, that doesn't match what I would expect from a 22-year-old. So you're already thinking something is off with this EKG. Then we've got someone with palpitations near syncope occurring with activity. So to me, in electrophysiology, that brings to mind several things. That brings to mind something called Brugada pattern. Pre-excitation has got to be up there. A long QT. And then there's other less common things like a arrhythmogenic right ventricular dysplasia, hypertrophic cardiomyopathy, other things that you would think about. But pre-excitation is, you got to look at that because an EKG will tell you if that's what's going on. So what is pre-excitation? Get my laser pointer again. So pre-excitation means that the ventricles are being stimulated earlier than normal. So how does that happen? Well, there's something called a bundle of Kent, which is an accessory pathway that occurs outside of the AV node. And so think about the atria. So we got the atria here, sinus node, and then the AV node is kind of connecting the atria and the ventricles. And think of the sinus node like if you were to drop a pebble in a pond, and it's going to ripple out and just spread. And that's essentially what the sinus node does. When there's electrical activation, it's spreading through the atria and it's going to make its way down to the AV node. You see that on EKG as a PR interval. Okay, so if you've got an accessory pathway, so that's occurring outside of the AV node, as that electricity ripples through the atria, it might get to that accessory pathway faster than it gets to the AV node. And so that's what we call pre-excitation. So we have a PR interval that's short. That makes sense because we're getting through to the AV node faster than normal. Okay, so let's point that out. On this EKG, we've got a PR interval that is short. Okay, definitely less than 120 milliseconds, which is going to be our normal cutoff. So that's step one. And then step two, why does the QRS look so wide? Because what we're seeing is the ventricles being stimulated from outside of the AV node, so farther away from that normal conduction tissue along the septum. And so that's why we have a delta wave, which is a slurring in the upstroke of the QRS. Okay? So that's why the QRS looks a little wide. We have a slurring in the upstroke of the QRS, short PR interval. So it's the combination of short PR interval, delta and a delta wave that we call pre-excitation. So ventricles are being stimulated early. Now, the most commonly chosen answer was hyperkalemia. Remember, hyperkalemia is going to be peaked T waves. So we don't really see that here. We don't see, so the T waves are going to look really, really big, and they're going to look usually as big or bigger than a QRS complex. So that is pre-excitation. Why do we care about pre-excitation? Why is that a can't miss EKG finding? This is the ultimate concern that we have, which looks crazy. It looks like a crazy EKG. So you remember FBI, fast, bizarre, irregular. hopefully you're not going to see this. What you're typically going to see is this, and then you're going to ask the patient, do you have any symptoms related to this? Palpitations, near syncope, maybe chest pain. So we care about this because if that accessory pathway is present, then it can potentially conduct very, very fast. So one of the coolest things I think about the electrical system in the heart is that the AV node has principles of refractoriness. There's a fancy term you can use. Principles of refractoriness means that the faster you try and make it go, the slower it's going to go. So for those of you that like to work out, and you might monitor your heart rate zones, and you have a predictable age predicted maximum heart rate, and that's based on principles of refractoriness. The AV node can only go so fast, and that's to prevent this from happening right here. So if you have, for instance, AFib, the atria are going 300 beats per minute. Well, that doesn't happen. We don't see a ventricular rate of 300 when patients are in AFib because the AV node says, not going to happen. It doesn't let it go that fast. So the accessory pathway, all bets are off. It can go as fast as it wants. That's why we care about delta waves. So pre-excitation, now most of the time, even that accessory pathway isn't going to conduct that fast because it's usually a little weaker than that. But you see pre-excitation, the patient has symptoms, that should raise concern of the potential that that pathway can conduct very fast. And if the patient were to develop some type of AFib, even a 22-year-old, because when we start having really rapid conduction, everything gets unstable and you can develop things like AFib or VFib. And that's why we care about that, because the accessory pathway is present if there's a delta wave in a short PR, and we want to know how fast it's able to conduct. So your job would be to recognize pre-excitation and refer to electrophysiology, where everyone gets really excited about delta waves. And so generally what we would do is we'd put that patient on a treadmill as long as they're stable. So we put them on a treadmill and if they've got a delta wave and they're not having symptoms. If they're having symptoms, take them to the cath lab and we're going to do an ablation. But you can put them on a treadmill and then in a controlled environment, see as you increase their heart rate, does that accessory pathway go away? Because usually that's what happens. And then electricity starts to shunt down the AV node. So you can actually see them go from pre-excitation to not pre-excitation. And you might actually see your patient have a delta wave pre-excitation one time, and they may not have it the other time. So it's whatever pathway is conducting the fastest. But you want to be able to recognize pre-excitation and refer that patient out for quick evaluation, especially if they're having symptoms like this patient is. We don't want to wait. We want to get that patient seen right away. Okay, move on to our next case. 50-year-old female with near syncope palpitations. She's got depression on citalopram, recently started on levofloxacin for pneumonia, and she's currently asymptomatic with stable vital signs. So think about what is going on based on that whole clinical picture. What is going on and why? Why do we think her EKG looks this way? Medication induced. Yes. Great job. Okay. Almost everybody picked medication induced, which is correct. We had some answer options for hyperkalemia because you're probably thinking about, I know potassium has something to do with this, but this is another one of the things that I would say is a can't miss. And no matter where you work, I think this is really important for primary care internal medicine providers to know about, because you're going to see these people on these really commonly used medications. And so this EKG shows QT prolongation. And when you think about QT prolongation, I want you to always remember three things that you want to look for. So one, you want to think about cardiac ischemia. Of course, ischemia can cause QT prolongation. And then the patient uh, can have medications that are doing this, QT prolonging medications, like in this case, and then hypokalemia, low potassium can increase the QT interval. So we can see this laser pointer, so I'll show you, really prevalent here in V3. Usually QT prolongation that's from medications, you're going to see it really prevalent in the precordial leads. That's where I typically see it. It's present everywhere, but it just seems to be a little bit more noticeable in those leads. Okay, so QT prolongation, don't trust the EKG print off, gives you the numbers. Don't trust it for QT prolongation. because it's rate related and it's not always accurate on the machine print off. But what you'll notice here, quick and easy way, find an RR interval. Okay, so R, R. Figure out where that QT comes back to baseline, and that QT interval should be less than half the RR interval. Okay, Q the T should be less than half the RR. And in this case, we can see it's definitely longer. Now, here's another thing you'll notice, because it can be difficult when the QT is prolonged to say, where does that come back down to baseline? But you'll also notice, because of the mechanism that we'll talk about next, of why this is happening, the T wave doesn't just nice and tidy come back down to baseline. It just sort of slurs back to baseline. Because what that's telling us about is a prolongation in the refractory period of the ventricle. That's why we care. That's why bad things happen. So um, long QT. Of course, we have genetic. Don't forget about that. So this patient, you're also going to ask about family history of sudden cardiac death. Could just be genetic. Acquired, think about these things. If you start combining medications, it's a setup for a prolongation of the QT. Now, not everybody gets that, because what we think the mechanism behind this is, we don't know for sure, but these people have some type of a channelopathy that predisposes them to not tolerate these medications well and have a prolongation of that QT. If you want to know the physiology behind it, if you remember this action potential, if we start prolonging it, so a prolongation of the QT reflects a prolongation of the refractory period, which is this end portion of the action potential. And so if you prolong that, there are several components here, and one is a relative refractory period and one is an absolute refractory period. Okay, so the absolute refractory period doesn't matter what you do, you can't change it. So but when you prolong the totality of that ventricular repolarization, you're going to prolong the absolute refractory period, which doesn't matter, but you're prolonging the relative refractory period too. And we're talking about milliseconds, but just prolonging that relative refractory period just enough. When we prolong that QT, prolonged ventricular repolarization, we create electrical instability in the ventricle. And this is what happens. So this was actually the previous EKG was one of my patients. And then this is what happened on telemetry. She was actually in the hospital, which made it much more convenient. But she started doing this later that day. And so what you'll see is you can hopefully appreciate the QT hard without another normal beat after, but this is a long QT. So that's literally reflecting this happening here. And if you get a PVC that falls at the end of the T wave, because the end of the T wave is where that relative refractory period is. And so when we have a PVC that falls at the end of a prolonged QT interval, now we can be off and running torsades. So QT prolongation, because it prolongs the relative refractory period, that creates electrical instability. There's another fun word you can use early after depolarizations, which are essentially just electrical instability PVCs that will fall there because we've created that instability within the heart. And now we have polymorphic VT. Polymorphic VT tends to be either self-terminating, recurrent, self-terminating, or they're just going to go straight into VF. That's why patients may come in and say they have this sudden onset of near syncope, palpitations, and then it goes away, and then it comes back. And that's essentially self-terminating. Okay, so prolongation of the QT, be aware. If you can help it, try not to combine these medications, especially then if you throw a little bit of low potassium into the mix, those patients are going to be in trouble. Okay, this is our last question. We almost made it. A 45-year-old man with sharp chest pain, worse when taking a deep breath, not been feeling great for a few days, cough, shortness of breath. There's the vital signs. Take a look at the EKG and see what you think. Give you a little bit of time here, and then we'll go into our last question. Okay, so here's the question, and you can take a look at the tracing one more time. Which of the following would be the best initial treatment based on what you think? So interpret the EKG and then figure out, how do I manage that? All right. So several options for activate the cath lab, followed by ibuprofen and colchicine. So this is an example of pericarditis. So first, want to think about the whole clinical presentation. Let's go back to that real quick. So we got a guy that's temps up, doesn't have a fever, temps up a little bit, not feeling great, sharp chest pain, worse when taking a deep breath. Okay, so that's the relevant clinical information. And then if we look at this tracing, what you'll see, many of you obviously picked out that there is ST segment elevation. But remember when I talked about reciprocal changes? That's why reciprocal changes are so helpful. Because if you have a STEMI, then you're going to have clear ST segment elevation in specific leads with ST segment depression in specific leads. And in this case, we just see this diffuse ST segment elevation in almost every lead. Because with pericarditis, we got inflammation, irritation of the myocardium, the whole thing, not just one specific section. So that's why I think I wanted to put this case at the end to really highlight, compare and contrast the STEMI versus other things that can cause ST segment elevation that we don't really get that excited about. The other thing that goes along with pericarditis is a slight drop in the PR interval, so depression of PR interval below baseline, which we can also appreciate. So that's one of the very few things that will do that is pericarditis. So we've got, we want to make sure we can identify the isoelectric baseline, and then we can see that there is clearly ST segment elevation, but I think I can see that really nicely in 2-3 AVF. So if I see that in 2-3 AVF, I should see ST segment depression in 1 and AVL if this is ischemic, but it's not, right? ST segment elevation there. So this is a great example of pericarditis. And in order to treat pericarditis, we use Motrin, we use ibuprofen and colchicine. So sometimes, or any NSAID, NSAIDs and colchicine. So take home points from that. Patient has recent flu-like illness or respiratory type symptoms, PR interval depression, uniform ST segment elevation without reciprocal changes, and we treat that very differently than we would obviously something like a STEMI. Okay, we have just a few minutes. If anybody has any questions?
Yeah. So thank you, Maureen, for an excellent, informative presentation. We'll go ahead and take some time for questions. Just a reminder, please be sure to type your questions into the question box in your control panel. Okay, we've got one. I just came from a workshop. Actually, you already answered that, correct? I
Yes.
just came from a workshop on reading. Okay. We've got one that came in. What is the difference between complete heart block and bundle branch block?
Okay, yes. So I touched on that a little bit, but the difference between a complete heart block and a bundle branch block, the main take home points is I think you don't want to miss complete heart block because you're focusing on the morphology of a potential bundle branch block. So recognizing that if there is complete heart block where there's a ventricular escape focus, it will typically have an appearance of a right bundle branch block or a left bundle branch block, but that's not the primary issue. You're seeing that because there is complete heart block and there's a ventricular escape focus. So the main difference is to look for AV dissociation.
Okay, our next question is, how does the treatment of a second degree type 1 and second degree type 2 block differ?
Yeah, with the second degree type 2, generally speaking, assuming no majorly reversible factors, that patient's going to require a pacemaker. Whereas a Mobitz type 1 or a second degree type 1 generally does not, unless there's additional types of heart block present, or if the ventricular rate is really slow. If they're dropping lots of QRS complexes, those are all things that might make you consider a pacemaker. But generally speaking, that's not gonna be your first line treatment for a Mobitz type 1 or a second degree type 1. That is more likely to be reversible.
Okay, and how do reciprocal changes help to diagnose a STEMI?
Yeah, the pericarditis example is great. A great example of that. You are going to, when you have SC segment elevation and it's from a STEMI and not from something else like pericarditis. When it's a STEMI, you're going to have reciprocal changes, which is reciprocal ST segment depression in classic characteristic disease. So you can pair those two things together to say yes, and you feel really good about this is a STEMI. Whereas in something like pericarditis, or if there's some other cause of ST segment elevation. And we didn't talk about things like an old aneurysm, aneurysmal MIs, we see a lot where an old MI that there's an inherent weakening in the ventricular wall. You can have persistent ST segment elevation from that as well, but it's not generally associated with reciprocal changes.
Okay. Most may know this, but how do you identify a J wave?
So J waves, if you see like Osborne waves, yeah, that's a great another great thing to think about with ST segment elevation. But J waves we see in like hypothermia is a classic time when you can see that. So I think that's the most common time you'll see it. And I always tell my students, if you want to see that, go to a cardiac unit and look for patients that are they're getting cardiac cooling protocols. And so you can see J waves. You can see as ST segment elevation, and I'm show you a picture, but at the end of the QRS, there's ST segment elevation, but it's not going to be that classic tombstoning. And it's almost has more of like a, it kind of dips down with the ST segment elevation as opposed to coming up. So I think clinical picture, those patients are going to look a lot different than someone who has ST segment elevation. And the heart rate is generally slower as well.
Okay. Can I get a specific abnormalities on EKG that must be sent to the ED for further evaluation? For example, ST elevation.
Sure. I think what are the urgent things? So I think you always want to pair the tracing with the patient, right? That's step one. Always treat the patient. So, but think STEMI is a yes all the time, absolutely. So I think STEMI, complete heart block, I would say also falls in that category. If you've got, and then other things like if you've got any type of heart rhythm issue with rapid rates, where there's issues with hemodynamic compromise, so AFib RVR, or if you've got PSVT RVR, BT, of course. So the really slow rates, whatever the cause, the really fast rates, whatever the cause, but specifically if the patient is symptomatic from that and hemodynamically unstable. AFib RVR, complete heart block, PSVT, patient symptomatic. Those are all things. Whereas even if you see like a simple pre-excitation and the patient's stable, I don't think you necessarily have to send that person right away. That could be an outpatient referral. Unless they're having symptoms related to that, then you would send them. That's a
Okay.
great question.
And our last question, forgive me if I'm pronouncing this wrong. Colchicine in my area is mostly used to treat gout. Is it an anti-inflammatory effects that would benefit the pericarditis?
You are exactly right. That's exactly right. So with colchicine, that is typically what we think about as a gout medication. And so if you weren't familiar with pericarditis, you'd say, what is that? Why would we use that? But there's actually a lot of really good data with the effects of colchicine on reducing cardiac inflammation. So it's a mainstay of therapy for pericarditis, but it's almost becoming a commonly used drug for other types of cardiac conditions. But for now, mainstay of drug therapy for the inflammation effects for pericarditis.
Okay, great. It looks like we've covered all of our questions. Thank you, everyone, for spending time with us today. And thank you again to our host, Maureen, for a great presentation. If you're interested in purchasing Presenter's book, EKGs for Nurse Practitioner and Physician Assistant, 4th edition, you will receive a 25% discount using webinar 25 at checkout on springerpub.com. The recorded session will be available on springerpub.com in 5 to 7 days. Wishing everyone a great afternoon, and we look forward to joining future Springer Publishing webinars. Thank you.